is Dr. Anwarul Islam. I'm a coordinator medical physicist, Scott Cancer Center. Today I'm going to present AI-driven auto-contouring and planning for breast cancer radiotherapy feasibility study on geometric and dosimetric accuracy. So this study is conducted along with my colleagues and also my two students, Mohammad Hasibul Haq and Istiaul Haq, and two other my colleagues, Ashim Kuapal and Abdul Sogu. So as you all know that if we think about the radiotherapy workflow, from the left figure, that the most crucial part, time-consuming part are tumor and organ contouring and treatment penetration. Most of the time we have to spend in the radiotherapy department in these two chapters. So you also know the quality of ABRT treatment planning depends on target coverage and normal tissue sparing. One of the main challenges in ABRT, accurate and efficient contouring and planning. That's the main challenge. And we are seeing that about 10 million new diagnoses each year. So the workload is very, very high global, worldwide. And all the patients undergone radiotherapy need to contouring. And many of the cases recontouring during the treatment, either the edema or the tumor shrinkage. So workload affect quality of radiotherapy because if you have the more patient need to be contouring, so definitely the fatigue arise and the workload definitely affect the quality of radiotherapy. So obviously, the one solution should need to be come forward, and this is obviously the AI. So before going to AI, let's see what we do in our daily clinical situation, that is a manual contouring. So what manual contouring do? Radiation oncologist create structure sets based on anatomical or functional information following different internationally standard consensus guideline. And organ sparing and operations depends on definition and installation of wear, appropriate consideration of movement. And definitely one thing, so the intra and intra-observed variability in contouring delineation in a common issue, because if you think about, so if you contour one patient and if the patient is contoured by different oncologists, there will be a variability. Not only that, the same doctor, if the contour in different time, there is chance to be variability. So inter and inter variability observation are always shown in our manual contouring. So now what are going to in modern world nowadays, that is auto contouring and auto contouring. So if we think about different auto contouring generation, that first of all the intensity analysis, which is we are familiar in our daily treatment planning system, that this is based on the city number or city voxel. As we see in our TPS, that if we contour some a region that have the same city number, like lung or brain, so this can be contoured in one click. And this is one kind of auto contour you can say. In TPS Eclipse treatment planning system, we are seeing that is segmentation result. And other things, our shape modeling, this is also we can calculate. We have to identify some part of this organ, and next the system can automatically do. This is called shape modeling. And another thing is atlas-based auto segmentation. So we are familiar because if we have a lot of patients data in your system, so we can create a library for that. And when we introduce a new case, this case will be then this case will need to be matched with a previous library case, and this contouring copied and pasted on this new system. This is atlas-based contouring, and actually non-deep machine learning is this system can automatically contour, but this system cannot recognize the organ, which organ is lung, which organ are other heart or other things they cannot understand. So that's why we need the supervised system, that we have to introduce one contour system to introduce him so that he can name this system. But if we exactly come the deep learning, this is a neural network based. This can learn from its data and always develop themselves inside. So early convolution neural network were used to segment two-dimensional pixel by pixels. Now fully connected layers of CNN with conventional layers of more effective segmentation, and the latest state-of-art architecture is UNetCNN. This is now help us to minimize the interperson variability and also reduce the sufficient workload in the department. So in our study, I have shown that evolution, we have taken geometric matrix, and which is let's say available in the in different publication. But dosimetric we do not, dosimetric matrix we do not have. But dosimetric parameters influenced not only by geometric precision but also spatial dose distribution and gradient. Each dosimetric parameter we have taken Dmax, Dmin, volume of percentage of dose has distinct reliance and sensitive to the geometric changes. So geometric input and dose domain plan quality remains one kind of illusion. So if we think, we said about the what we have to aim of the study to measure the savings of anatomical using AI-based auto-contouring system, as I already said, to gather object feedback of physician on contouring inequality of auto-contour and tools, to continually investing in the quality and accuracy of the structure, configuration either wholly, apart or partially by auto-contouring. So actually we can not put more details. So objective. So we have in our study we have taken the auto-contouring system version 2.5 and the planning purpose is influence both on them from red formation. This is available in the market, and the image we have taken from the lattice speed simulator, and our study has taken also variant eclipse 13.6 version. All the physical and geometrical data we have analyzed with a MATLAB-based program. 20 patients have taken here, and all the patients we have taken only 3 CRT. So the workflow, if I say that we have taken the breast 20 breast cancer here, so we have import this each patient will import in the auto-contouring system, and this auto-contouring system give us a contour image. This is called AI contour. After getting this AI contour, a doctor edits some part if needed, and that's I call auto contour. And as well, previously doctor contour manually the same patient or the previous patient manually contour in eclipse. So here we compare only auto contour and manual contour for different geometric and dosimetric evaluation. There are some statistical parameters. Null hypothesis and different p-value are here. So time evaluation, we have taken the treatment contouring time for manually and the contouring time for auto. This is auto contouring system given here. And then we have make a relationship, the time savings relationship in the right side. The severe correction, the quality evaluation of the severe correction, that's large and obvious error. Medium correction need when minor error to need a small amount of editing. Slight correction accepted minor error, but these are clinically not significant. And no correction means contours is very precise with the treatment planning system. And if we see about geometric evaluation, here you can see. After getting the auto contouring from this auto contouring software, we have compared with this with our manual system. In dissimilarity coefficient from this relation, we can see if both have the same volume and if the ratio should be 1. So our optimal goal for dissimilarity coefficient should be 1, and 0 means both contouring are not overlap. And house plane distance, actually distance between two contour surface, and this should also be 0. And 1 means greater than 1 means no overlap. And definitely we have also calculated the relative volume difference between this manual contour and auto contour, and we have also considered for the evaluation. And for dosimetric evaluation for OER, I have taken the auto contour and manual contouring and take the difference for Dmax, Dmin or D, 0 thesis or dose, and If for PTB, we, as we all know, that two quantitative and physical quantitative analysis, Houseman units homogeneity units and conformity units, and we have taken their differences between auto and manual. So, as we know that each patient have different parameters. So, we have created virtual physician doctors contouring so that this can accommodate between the geometric and dosimetric parameters. So, this organ we have taken different score, linear and threshold. Linear means if the dose is within our tolerance or near our tolerance, we have taken either full mark or 50% or 50% mark. And threshold, that means it's like a binary. When this is as if the dose, this is full marks, and if it's not, this is 0. So if we put all these in each patients, we will get another specific plan quality matrix for each patient, and then we have taken the maximum plan quality matrix value and normalize it, normalize for plan quality matrix times 100. So that's actually will this plan quality matrix will evaluate for all cases. And if we go for a result in our time savings, we can think that you can see this for average manual contouring times for breast cancer is taken 28 minutes, and T-auto means AI contouring plus doctor editing average time is taken 9.8 minutes. So time savings is 18.2 minutes, which is saved 65%. And same things for planning, we are saving 73% of time for this planning system. So quality evaluation, that means in the green there is no blue needs no correction, and 95 over the 95 is accepted, and if it is gold red mark, this is need to be corrected. And geometric parameters, AI versus auto, more than 95% similarity you have seen. It can show up to 12 minutes per house of distance, and almost no volume difference have shown. So for manual versus auto spinal cord, we see the dissimilarity coefficient less than 0.5, which one 60%, 61% relative volume difference have shown. Control lateral based is more than 20% volume difference. And thyroid shows 69% and high esophagus or T base also shown. As because if you can see the spinal cord when doctor contour or other contour, that should not be started from the beginning and not stop at the end. This is only contour from only PTB part only. That's the difference. I'm not going so much. And if you see our dosimetric comparison, continental based regarding Dmax difference, continental based 30%, spinal cord 12%, and heart 14%. And D-mean continental based is 14%, spinal cord 49%, and esophagus is 49%. And if we see about the 1 pixel, that means D03cc volume, continental based shows 31% volume difference, and spinal cord 10%, and heart 14%. And none of the wire does not have found the statistic equal, because we have taken more than 95% significance level, that means p value greater than or equal 0.05, except the following: contralateral base showed lesser value than 0.045%, and spinal cord and skin shows 0.001%, because we are taking that the both organs should be the same. But geometric and dosimetric evaluation, some part it needs a yellow significant difference, and red marks higher difference for organometrics, and geometric dissimilarity coefficient out of distance and relative difference, and for dosimetric difference here we have shown. And if we overall see the result, normalized plan quality matrix, which already I mentioned in previous slide. Normalized plan quality is for best if we take the mean standard deviation of continuous patients, such is around 7%, and standard deviation 0.16, And though our patient have no the continuation and the similarity of the different cases, so we have taken actually median ranges. And median ranges reference is 0.002 to 0.005, but our result is 0. That means in prime quality matrix, in virtual physician integration, actually we have taken, at the end we have no difference we have found. So if I say about the conclusion, auto contouring system active state of art, geometrical and dosimetric parameters, human dribble is still unavoidable, and AI-driven auto contouring would be important to speed up the contouring process over in present clinical practices. Plan-based automatically generated contour do not overdose nearby OAR. AI-based auto contouring may help to establish a standardized point of radiation therapy treatment. This study offers a proof of concept of methodology to investigate the impact of including an auto contouring and planning software in the RT workflow. Thank you.